Yeah. All right, good morning, everybody. Thank you for coming to the talk here. My name is Andrew Chou from Brigham. This is Alex Janke from Michigan, as well as Ari Friedman from University of Pennsylvania. We've all been there before. We've all been medical students and thinking that we'll answer every single question with a randomized controlled trial because we've been shown something like this. RCT, the holy grail, the golden nugget, the best evidence that's there available, that's what we're striving for. You know, maybe we'll tolerate prospective observational study, but don't even talk about retrospective and cross-sectional, please don't even bring it up, right? It's like that's the terrible study that people always talk about when we're growing up. But then as we grew up, we faced with reality. We don't have time, we don't have money, we don't have the heart to write love letters to IRB to try to get things approved, we don't have the RAs that work hard for us, that seem everybody else has. So we ended up doing what we swear we wouldn't do, which is the cross-sectional studies or retrospective studies. We use other people's data so that we can at least get our career started. And that's unfortunately end up being about 95% of the evidence out there just because it's really, really hard to get funding and time to actually do the prospective stuff. So we're here to tell you that hopefully there's a better solution here, natural experiments, AKA quasi-experimental studies. This is really just a framework to design studies so that we can minimize bias in a retrospective observational study so that hopefully we can achieve the strength of evidence that's approaching a randomized controlled trial, if not just as good, while preserving a feasibility of doing a study with existing data in an observational study framework so that we can at least create something that's meaningfully contribute meaningfully to the literature. Our goal today is to really go through a couple of designs so that we can give you the language so that when you're thinking about study designs, when you're thinking about talking to your statistician, talking to the methods person, and answering your question, that is it possible for us to use some type of natural experiment or quasi-experimental design so that our study is no longer just correlations, not causation. It's just association. We can't prove anything. That we can do one more step than that to say that, you know what, there probably is causality here. We'll go through 3 specific type of study designs, and we'll go through kind of example papers of why they use this design, and how the general design works here. And hopefully, again, to give you the language to discuss this. The first study design is differences. Now, I think the scenario I want you to think about is 2014, Medicaid expansion just came out. And certain states decided to do them, other states didn't. You can't really do a trial on such a scale, but it is possible to do something called difference in difference. The assumption here is that when the difference in difference, the way it's termed is exactly as shown. So there's the difference before the Medicaid expansion, and then there's difference after Medicaid expansion. And presumably, if there wasn't a Medicaid expansion, the difference between the expansion states and non-expansion state will probably stay the same. But if we see a difference in the states that expanded Medicaid, and that the difference after that between the 2 groups of states is different than the before, then we think that probably that change may be reasonably attributed to the Medicaid expansion, okay? And the assumption here, it lies heavily on the assumption that when it's the difference before Medicaid expansion is gonna be the same had there not been any treatment, meaning Medicaid expansion. So if there's any difference in the treatment effect being here, and that's the difference in differences. It relies heavily on a couple of assumptions. One is that obviously there's only one event that happened to a particular group of people. So kind of similar considerations to RCT. You want to make sure there's nothing else that's happening. You want to make sure that the control group didn't expose to other things concurrently at the same time. There wasn't too much crossover there wasn't too much spillover either. So these are terms that you may hear in RCTs. The other thing that's unique to differences is something called a parallel trends assumption. And that's the assumption that I mentioned a little bit briefly earlier, which is that at the baseline, the difference has been the same between the two groups, so that we can safely assume that had there been no treatment or no intervention, the difference will remain the same after that period of the intervention was implemented. And that if we observe any change in that difference, and that will be attributable to the intervention that we talked about. So this is from one of the analyses I did a couple years ago. And as you can see, in 2012, 2013, pretty similar rates between expansion and non-expansion states. But as you move past 2014 and later, you can see that there's not much change or difference between in the ED visits due to if patients believe that they're actually sick, which makes sense, more coverage, you're still thinking you're sick, you still go to the ED. But for patients who show up in the ED because they didn't have any other option, there's a meaningful decline in those visits in an expansion stage. So this would be one way of how to demonstrate difference in different studies. So this is next.
So the next type of natural experiment is regression discontinuity. And I think the best possible example and most compelling for our practice setting is the discontinuity that happens when the D-dimer is just above the cutoff. So this is from a really cool study in JAMA Internal Medicine where the exposure is contrast CT. And what we're interested in is whether or not patients who are just above the D-dimer cutoff are more likely to have new renal impairment because they received the contrast. What we're looking at on the left-hand side is the likelihood that you get a contrast CT based on your D-dimer cutoff level relative to the cutoff. So the vast majority of patients who don't have a positive D-dimer do not get contrast for a CTPE, around 5% when they're just below the cutoff, and that jumps up to 30%. But patients that are around that cutoff are otherwise very similar. So on the other side, you're looking at the potential confounder. Well, just to the left and just to the right of the cutoff, the patients otherwise are of similar ages. And when we look at the outcome on one side or the other of the cutoff, we see that the estimated GFR at 6 months is also very, very similar. And so this was an example of a natural experiment that addresses among patients who are just above and below the D-dimer cutoff. Does the contrast that they receive appear to be related to their GFR at 6 months? The answer was no. Regression discontinuity's assumptions are you need the exposure just above and below the threshold to be different, which is to say, if the dimer was above 0.5, the patient did get a CT, and the reason that they got a CT was because of that difference. There has to be sufficient statistical power around the discontinuity, so you can imagine having a patient population where everybody's D-dimers are either 0 or 5. That is not a patient population where you can do a regression discontinuity. And then the last item is that there aren't other variables that share the discontinuity. So it's not as though we expect most patients just above and below the cutoff to be different in some other systematic way. There are lots of interesting potential opportunities to apply this, but one other example is that we have a propensity to test for acute coronary syndrome that increases in a discontinuous way around the age of 40. And so those are the types of opportunities that we could find.
All right, so I'm a walker, so I'm gonna walk. And we're running remarkably ahead of schedule. So I'm gonna talk a little bit about instrumental variables. And then I think just to prime you, start thinking of ideas in your life or questions that you care about, and we can maybe talk about how we might answer those using natural experiments in 5 minutes. All right, so instrumental variables are sort of the dream of the 90s in some sense at this point. There was a causal revolution in economics, and everybody got very excited about instrumental variables, and then people started pointing out problems. And at this point, they're still an incredibly useful tool that you have to be really cautious in how you use, because a lot of things that start out seeming like they'd be great instruments turn out to have problems. So, but then the papers that use them really well turn out to be really impactful. So what the heck is an instrument? All right. So you are working in Princeton, New Jersey, and you have a new pill that you really want, or an old pill that you think you want to see, is it causing an outcome? Death, right? So you go to your hospital administrator and you get a dump of 50 years of charts, and you look and you see that indeed getting that pill is correlated with death. And then your medical student, as you're presenting this on your findings on morning rounds excitedly, says, I remember my freshman statistics class, and correlation is not causation. And then you're all sad, because that's how that works for you. But then you remember that you have this quirky doctor in Princeton, New Jersey, and his name is Dr. House. And the way that Dr. House works is that every day for the last 50 years, every time he sees a patient with this condition, he flips a coin. And if the coin comes up heads, he gives the patient the pill. And if the coin comes up tails, he didn't give the patient the pill. So you say, gosh, that's great, right? So that sure seems a lot like an experiment, right? But at the same time, it's a retrospective observational study that Andrew just told us was like crappy evidence, right? So that's kind of the idea of natural experiments, and in this case, that would be a perfect instrument. And so we can talk, like an instrumental variable analysis is a statistical technique to analyze data that looks a lot like that, right? And so, we don't always have coin flips, but in the emergency department, we certainly have pretty random arrivals of patients, right? And we have pretty random provider shifts, and we have lots of randomness, When a patient arrives when it's crowded is pretty random, right? So, okay. So I'm gonna skip the graphs. We'll skip the graphs. So IVs have some strong assumptions that they make that you have to make sure that you're satisfying in an IV analysis. The first is instrument strength. So imagine you have another doctor, Dr. Janke, and he also has been working at Princeton Hospital, Princeton General, for 50 years, and he is also a little quirky, and every time he sees a patient with this condition, he flips a coin, but he's not crazy like Dr. House, and so he doesn't determine his treatment based on whether the coin comes up heads or tails. And so that's a weak instrument now, or a very weak instrument, right? And that will cause your IV analysis to blow up very quickly. We can just focus on the exclusion restriction for now and say the other question is, or the other assumption is that your instrument has to be related to your outcome only through your treatment, right? So if instead of a coin flip, it was, the particular doctor, right? If we just say, well, Dr. House really likes that pill, and so he gives it a lot, Dr. House may be doing other things that would affect your outcome in those patients, like giving them heavy metals into their bloodstream or something. Okay. All right. Another thing to note about AVs is that they kind of toss out an enormous amount of data. They basically work by tossing out all of the variation between your instrument and your treatment. They toss out all the variation between your instrument and your outcome that's not related to your treatment, right? Or another way to think about that is if you think about it as the first stage regression, that you're basically predicting your treatment variable instead of using your observed treatment variable. And so you're tossing out, right? You're just using the predictions along the regression line in this first stage of the instrument to the treatment, for those of you who think that way. Okay. Let's talk about one study very quickly. How are we doing on time? Okay. we'll talk about one study very quickly, and then let's talk about some natural experiments. So this is Dave Chan and I don't know her first name, Chen's paper, The Productivity of Professions. It's a working paper they posted recently. Basically, they try to look at the effect of being seen by a nurse practitioner or a physician on your outcomes, right? So this is like a classic thing that you might need a natural experiment for, right? Because obviously, how sick you are is correlated to whether you see a nurse practitioner or physician, right? Hopefully, how sick you are is correlated with whether if your system is working well, right? If triage is working well. And so what they do is they say, well, yes, but it turns out that in the VA where they're studying this, there's some shifts that have more NPs on them, and there are some shifts that have more physicians on them in their staffing. And so they use the number of NPs on a shift as an instrument for a particular patient being seen by an NP, right? And so they're basically only looking at the variation in whether you're seen by an NP or not that's due to the number of NPs on the shift, right? And they're tossing out all the other variation, because all the other variation sure gets you nice p-values and statistical power, but it's confounded, right? Okay. Their instrument was this is like a beautiful paper. You should read this paper. Their instrument was very strong. The probability of being treated by an NP increases as there are more NPs around, right? Like, that's an easy one. They have, random assignment of shifts, and they do some tests around that. And then they show, and I think it's reasonable that they're satisfying the exclusion restriction, right? So the key question for them here is, could the number of NPs on a shift somehow affect the physicians on a shift, right, which is kind of their control group here, and the outcome that way? And so that would be like a link between the number of NPs on a shift and outcomes that wasn't directly related to being assigned an NP. And so they show that that's not true in their data. Yeah, all right. So this is like natural experiments are good. But let's talk about some natural experiments. So what's on your mind?
Yeah.
Oh yeah, you finish up and then, yeah.
Thank you. So that's a really brief overview, again, of 3 different types of natural experiment designs that we went through. Again, our goal is so that you kind of know these exist, and these are the language that you can use when you're thinking about a study problem and talking about it with a statistician or a methodologist to see, is it possible for us to answer this question using a natural experiment such as difference in difference, regression discontinuity, or instrumental variable analysis, or natural randomization. Yeah, and so that we can bypass the historical hindrance of, oh, this is an observational study, that there's bias, that we can't really make causality. And to also make it feasible so that we don't have to do our RCT to answer these questions. And so hopefully with this, you can have these language in our armamentarium, so as we talk and going forward, we can make basically studies that are impactful for people who basically have less resources to do. And hopefully this was helpful to you all. We can take any questions as well. And sorry, this is an older version of slides, so there's no contact on there. All right, thank you very much. Any questions? We're good? Great.
So like what do you think? What do you study that you could maybe think of as a natural experiment? Or I'll ask differently. So Kathy, you mentioned earlier, what other research designs are you looking at? Okay. Mm-hmm. Like over multiple events?
Yes.
Mm-hmm.
Basically different nodes within the VA, so different visits, different teleworking care at different times.
Oh, yeah, like an event study. Yeah.
I haven't actually done it, so I don't know any of the methods, but I'm told that it should work.
Yeah. Happy to talk about those. I'm a big fan of event studies, right? So just for everybody, so like we talked about differences and differences, and those were really took a big leap in their methodology around the ACA, and the ACA is a single event, or at least when we started doing these studies in economics, it looked like a single event, and then people started pointing out that, like, gosh, there were a bunch of different states expanding Medicaid, and then over 5, 6, 7 years, and Andrew Goodman Bacon, and it was, I'm forgetting her name, but anyway, there were three kind of key papers which came out showing that when you have varying event timing, you're kind of messing up your control group, because things are sometimes in the treatment group and sometimes in the control group, and it just you're not really estimating what you think you're estimating anymore. And so in 2018, the new methods started coming out, basically. So, like, I went away for my PhD, I did my PhD in health economics, went away to residency, and came back, and, like, all the methods had changed. So these are super new methods, but yeah, highly recommended. For event studies, always start with a two-way fixed effect. It's not that hard to do, and it's still, I think, the standard, and then can look at some of the newer, fancier estimators on top of that and see if it makes any difference, because they're designed to solve, like, particular problems that don't always exist in your data, and a two-way fixed effect's a little easier to understand. So, like, Athene Venkataramani's paper in JAMA on like factory closures and what that's impact is on health, uses two-way fixed effects, and then Atheve Mehrotra, Bill Wang, and my paper in Health Affairs on urgent care clinics uses two-way fixed effects. So I would start there, and then if you see a signal there and you want to make your reviewers happier, then start switching to the newest methods. But, like, 2018, like 5 years old, is pretty new for a statistical method already. So anyway, but I would love to chat. That would be super fun. So please reach out.
It's going to be okay for clinical journal. They have no clue.
Certainly difference in difference is pretty well.
Yeah.
Yeah.
But like regression, discontinuity, and unethical analysis, it took me so long to, like, understand. I'm sure I fully understand regression discontinuity yet. But, like, does it seem to confuse?
Yes.
So here's my thought. If you're going to use the latest methods, if you're going to do an RD or you're going to do an event study, you should be studying a topic that you can publish in JAMA, because JAMA understands it, right? Annals would reject you. Does that make sense? Like, it needs to be a general interest topic, not an EM specific topic. And as much as I think that general interest journals should care about the ED more, like, sometimes they don't. So, I would target it that way, because otherwise you're going to have an uphill battle convincing the reviewer that this new fancy thing is real, and you're going to spend a lot of your time showing that it also holds in whatever older method they want to see, and then if there are any differences there, then you're really going to be in trouble. So that's how I would approach that tactically.
All right, we should yield the room to the next one.
All right.
Thank you.
Thanks
guys.
so much
Thank
for
you,
coming,
everybody,
guys.
for coming.
It's Friday, and everybody's about to get on their plane, and we're so glad you're here.